fel, närmare rätt. Ett sätt att se på saken brukar svälja dina lögner mest för att få känna.
Hello everyone, quick disclaimer before we get into our interview with Dr. Marc Strauss. So what happens sometimes with internationally, language kind of gets confused. So to set the record straight, when I am talking about athletic trainers, I'm talking in the United States, I'm talking about athletic trainers, which is a healthcare provider for active individuals within the United States, a licensed and certified healthcare profession. When Marc Strauss refers to athletic trainers, that's kind of what's similar to a strength and conditioning specialist within the United States. So just so you guys know before we get started, when he speaks to athletic trainers, not a healthcare provider talking about strength and conditioning person that's focused just on improving someone's physical fitness, and athletic trainers, a healthcare provider for active individuals, but also can provide some strength and conditioning training, and rehabilitation. So just a quick difference between those. So thanks. Let's get started. Hello, my name is Tim Andrews. I am an athletic trainer in the Indiana State Doctor of Athletic Training program. I'm here today with Dr. Marc Strauss, who is an orthopedic surgeon who in Norway, and he has a subspecialization in complex knee injuries and sports medicine. He has an IOC sports medicine diploma. He works for the Oslo University Hospital. He is also a physician for the Norwegian Olympic Center and a team physician for the Norwegian Alpine Ski Team. How's it going today, Marc?
Good, thank you. And you?
I'm doing good. Thanks for talking with me today.
Pardon me?
I said thank you for talking with me today.
My pleasure. Looking forward to it.
So can you talk a little bit about your background and what kind of got you into this field?
Yeah. Well, actually, I grew up in the States from when I was 10, about 12 to 20 years old. And then I went back to Denmark. I'm Danish originally. Got accepted to med school in Denmark, and it's an 8-year program where you do undergrad and grad in the same block. So once you get into undergrad in the medicine program, then you can fulfill the postgrad or the medical school part of it as well. So it's an 8-year program you get accepted into. After I finished med school, I did my residency in Denmark. And after residency, I was actually pursuing trauma surgery when I had a great offer at the leading sports medicine institute in Denmark, in Aarhus. Was asked if I was interested in a position there. So I did a 2-year subspecialization with the Professor Martin Lind, who is a renowned knee surgeon. And so that's how I sort of ended up in the arthroscopic knee surgery and the sports medicine. During my residency, I was active in sports medicine. I was working for the Danish National Soccer Association, working for the U16 and U19 national soccer teams. And after I did my 2 years of postgraduate training with Martin Lind, I had an opportunity to go to Norway to Professor Lars Ingebretsen, where I did a 1-year clinical fellowship. After my clinical fellowship, I was offered a job by Professor Ingebretsen to stay with the Oslo team, which my family and we would love. So we, of course, said yes to this. And I've been in Norway ever since 2012. This year, however, I spent 1 year in the US. I'm currently at the Steadman Clinic, or Steadman-Philpott Research Institute. So I took 1 year off clinic at the moment to do my PhD, so to pursue more academics.
Okay.
So I'm doing my PhD on the quad tendon for ACL reconstructions.
Okay. So I guess it's kind of unique. I think a lot of people will be surprised that an MD would want to get their PhD. What kind of sparked that interest for you? Why do you want to go back and do another?
Well, I think my path is a little bit different than most, in the sense that I've always believed that having focus on the clinical aspects and then becoming a good surgeon is important. But I must admit, throughout my whole career, everybody has been telling me, you have to do research, you have to do research. And it's becoming more and more popular trend in especially Scandinavia for orthopedics to do PhDs. However, most people, I think, pursue their PhD right after med school, or even during med school. So I sort of flipped it all upside down a little bit, and I pursued my clinical career first. And then I got to a point in my career where I felt that now I'm asking more questions than I have answers. But I definitely, I don't think I was ready to do a PhD right out of med school. I was too hungry to do surgery, and couldn't find the peace of mind to sit down and do research, because it takes a lot of dedication. It takes time, and it's really time consuming. And it really you need to find a subject or an area that you really are intrigued by and want to pursue and spend a lot of time doing that.
Yeah, definitely have to have a passion for it in order to do all the research. Yeah,
absolutely. And I think for me, I started feeling that inner ease in the sense that I felt like I've done pretty much the surgery I've always tried to pursue and always been challenged by, and felt I got to a point in my life where I can say, okay, I've done this, I've seen that, it's been there. Now I can relax a little bit. I'm not as eager to, I want to have this case, I want to have that case, where now I can have another focus, and that's more the academic world. So for my sake, it was a little bit upside down of what most people actually do.
Yeah. What benefit have you found from doing this so far?
I think, the benefits in general are, of course, you get a better in-depth understanding of what's going on, how research is pursued, and the time and commitment it takes. But I think for my sake, having that ease of mind and having that curiosity now driving me in my research has given me that, what do you say, like it's made me understand it, made me want to pursue it more than I've ever wanted to pursue before. And it felt like a natural point in my career to take that break and say, okay, this is what I'm going to do. Normally, we have several colleagues that pursue a PhD also later in their career, but they would do it as a part-time commitment at still being in the clinic, maybe 50%, and then do a PhD part-time, 50% over about a 6-year period, whereas normally a Scandinavian PhD is a 3-year full-time program. So what we've done here is we've sort of done a crash course in PhD here, in the sense that we're doing all my studies in 1 year here at the Steppman Clinic. Now when I go back to full-time clinic, and then I'll have to write up my thesis once I go back.
Wow, so really, really condensed 3 years to 1 year. I could definitely see that being very, very intense.
Yeah, but if you have the setting around you and you have the right studies, and there was a lot of pre-planning before we came here. So we didn't come here starting from scratch, in the sense that you have to plan your PhD, you have to write up a manuscript or proposal for your PhD and back and forth. All this was done ahead of time. So when I got here, we've already had protocols for all my studies, and it was just a matter of getting my studies done. Also, my studies are basic science studies. So there are studies we can do in the lab, where the non-clinical studies in my PhD. Clinical studies take a lot of time. So in a setting as we have here at the Steppman Philippon Research Institute, there's really a great team around you, and everybody is helping out. It's a really big team effort here. So you can really get a lot of stuff done here in a short period compared to a lot of other places.
So is that kind of one of the reasons?
We couldn't have done this setting back home in Oslo, so that's one of the reasons why. Yeah, that's definitely one of the reasons why I pursued coming here. And there's a long collaboration between the Oslo Sports Trauma Research Center, where Professor Ingebretsen is the head of, and with the Steppman Clinic. They go back 10, 15 years with a collaboration on research. So we've had several Norwegians coming here to do research and PhDs over the past many years, and a lot of good and award-winning publications have come out of this place. Absolutely.
That's awesome that you have that kind of collaboration between the two sites. Could you go into a little depth about like what is the Sports Trauma Research Center?
The Oslo Sports Trauma Research Center is it's at the School of Sports Medicine and Sciences in Oslo. So this is a different college compared to Oslo University. And this is where people, if they want to pursue sports as an education, they attend there. They have undergraduate and graduate programs, so you can do both your master and your PhD at this school. And it's a big research institution also that has developed over the years with Professor Roald Barr and Lars Engebretsen, who's been leading the center and developed into quite the research center. So they're heading up the research for the FIS program for the International Ski Federation, have a great collaboration with FIFA, the European Soccer Federation, and the Olympic Federation as well. So Professor Engebretsen is head of scientific research at the Olympic Committee. So that way around, there's been a great collaboration that's been developing over the years. So a lot of the prevention programs and research has come out of the OSTRC, and a lot of the FIFA programs like prevention programs, and also the surveillance systems for the IOC. A lot of it is in collaboration with the OSTRC.
Yeah, it's definitely important to have that collaboration between the different areas, both the science and the federations, to kind of work together to accomplish a goal.
Absolutely.
So I guess my first kind of question. You sounds like you have a lot of different roles. You've had a lot of different experiences, but I guess what's your typical day look like?
Well, my normal clinical day, I have a full-time position at University Hospital. So I have a Monday through Friday clinic, anywhere between 3 to 4 OR days and 1 to 2 clinical days. Then I also do senior consultant on call. So we back up. We're a level 1 trauma center. So we do trauma calls. So we have very, very experienced residents and junior attendings. So it's rarely we get called in, but it's typically in the cases where they really need an extra hand or an opinion. I have called typically once a week, and then every 8th weekend. And then besides that, on Wednesdays, typically, I have a clinic at the Olympic Training Center. So once I'm done at the University Hospital, I head to the Olympic Training Center. And then I have a clinic there where we see patients from all over the country, most of them top athletes. And if we have available spots, when I say we, it's Professor Engebretsen and I, if we have available spots in our schedule, then people that are not top athletes can actually get a consultation at the Olympic Training Center. But they're definitely reserved for top athletes who are typically Olympic qualifying athletes or World Championship qualifying athletes.
Okay. So it's kind of everyone that's really on the Olympic team that you're seeing then.
Yeah, so we see a wide variety of athletes. So it's not just one type. It's all both the summer and winter Olympics, and also the other sports that are not necessarily an Olympic sport. Plus, we cover the Norwegian Opera House, so we see the ballet dancers as well. They're covered under the Olympic Training Center.
That's cool.
Yeah, so it's a lot of diversity, and it's a different way of working than what we're used to as orthopedic surgeons, where we mostly assess surgery, non-surgical approach. Here, there's a lot of overuse injuries, a lot more sports medicine than orthopedic surgery cases. So I think it gives a nice diversity and a nice challenge throughout your daily practice and keeps you on your toes. And I think I would probably get bored if I was just doing simple orthopedics all the time.
Gotta have variety, right?
Yeah, absolutely.
That is a good thing about sports medicine, is everything's a little different.
Yeah, absolutely. There's a lot of challenges, a lot of psychology, a lot of challenges, both with, in general, you can say that working in the hospital, you have a patient and you make a joint consensus with the patient on what's going to happen, and there's the offer of surgery and non-surgical treatment. And then with the patients, you figure out how you want to approach this. But with athletes, it's very different because you don't just have the athlete, you also have coaches, and sometimes young athletes, you have parents or family involved making big decisions, and timing of potential time off any kind of activity or surgical procedure, and especially the rehab. How quick can you get the rehab done, and can you get it done more efficient than a general patient at the University Hospital? Then besides that, then for the ski team, then I'm available 24/7 by phone or email. Over the last couple of years, I've been traveling less and less with the ski team. Initially, I traveled, the first year I traveled quite a bit with them, also to get acquainted with all the athletes. Now I've been with the ski team almost 6 years, so I know most of my athletes quite well. And I've developed a good international network of people I trust and that I know are sound clinicians and can give me a really thorough and good assessment of potential injury, even if in Argentina or Chile or somewhere in Europe. Then I have a good, close communication with the physicians that are attending them. And then from there, we can make a joint decision on what's going to happen. Are we going to do a surgical procedure in a foreign country, or are we going to take our athlete home and then do the further treatment back home? So it's a 24-hour job pretty much.
But I mean, it's great that you guys all kind of collaborate together and work together to kind of service all the athletes at once. It's really helpful to kind of know and have that trust with each other.
Yeah, I think, and I think it's, at least for the ski federation, I've sensed that it's becoming more and more common. I think over the last couple of years, there's been some terrible accidents. Alpine ski racing, especially speed events, it's a brutal sport. It's a Formula One on skis, and it definitely has consequences when they crash. And we've had several mortalities in the last couple of years, and that just keeps everybody on their toes. And it's become I feel like a little community, a little family among the medical personnel. So everybody's have a great understanding and respect for the sport and for our athletes. So I think it's unfortunately, like I said, a couple of fatalities, but it's also brought us a lot closer together and willing to cooperate across borders. Definitely.
Great. Are there any challenges with that kind of collaboration, working with each other with different countries and all that?
Well, there are always challenges. And that's why for me it was important to pick out a couple people in each country or continent that I can trust, that I know that these people are sound clinicians, they're good people. Because working with top athletes, of course, if we were to say that Tom Brady and the New England Patriots were to travel to Europe for some kind of event, and they didn't have a physician with them, and Tom Brady got injured, I'm sure there would be a lot of physicians that would queue up and to say, I can do your case for you, and to put that on their CV. And that's where you need that mutual respect among colleagues to accept and say, okay, I know he needs surgery, but this is not my job to do, or this is not the time to do it. He's better off going back home, or a similar situation like that. So when we have these people that I collaborate with, I know when they say he needs surgery now, then I know that is the case, and that is the assessment, the medical assessment of it.
Yeah, it's definitely great. I mean, unfortunately, that's kind of the issue of, working with high-level sports is, everyone wants to work those high-level cases and stuff, but being a practitioner and kind of understanding I need to focus on what's best for the patient is definitely a very important skill to have, and
absolutely
have that realization.
Yeah.
So what does when you're working with the Alpine Ski Team, and you're traveling with the team, what does your day look like there?
Those days are very different. I mean, I am an early riser also in my daily practice, but alpine skiers are very early risers. So typically we will be up and about around 5 a.m. and typically heading out between 5:30 and 6, preferably on the slope. but anywhere between 6:30 and 7:30. For the practice part of it, then they have typically a practice in the morning. As soon as they like the snow being ice and not snow. So it typically has to be really hard packed and icy conditions, then it's optimal for the skiers. And then there will be a couple practice runs. It will typically be a 2-hour session or something like that. So my job on those 2-hour sessions is not as just an orthopedic surgeon or a doctor attending the practice session. I help out with anything. Okay. I carry gates, I take down gates, I inspect the course, I make sure there's not a rock on the course. I go pick up food or whatever is needed. So everybody pitches in. Nobody is better than others. And it's really a team effort on a Norwegian ski team. So yeah, officially I might be the team doctor, but if the coach tells me to drive down and get some stuff, I drive down and get some stuff. It's quite easy. Everybody pitches in, and it's a good, everybody respects each other. So I don't just sit around and wait for something to happen. But as the doctor as well, for that role, being on the slope, so typically on speed events, I'm on the top in case something happens, because then I can ski down. Yep. For the tech events, which are slalom and giant slalom, the courses are much shorter, the speed is much lower, so typically I'll be waiting on the bottom. Okay. And then we can snow scooter up if anything. And once the practice session is over, we go back to the hotel or whatever. The athletes, they rest up a little bit. We have a lunch. And then there's afternoon practice. That can be a second practice session on ice. Most likely it's a dry land session. I like to participate in those. It keeps me a little bit on my toes and on shape. But I do also have time, more time than I have back home in my daily schedule. So it gives me time to catch up on some of the research and article reading and get sorted out my emails and things like that. So it's also a time where I do tend to relax more than I do back home. Go to bed very early. We try to put the athletes to bed by 9 o'clock. No screen time in the evening. Race days are, of course, different. Much more intense, much more stress. And those are long days. Those are days from 4:35 in the morning till late evening for all the supporting staff. That includes coaches, technicians, medical staff, sponsors, whoever is around. So we try to make things as smooth and easy for the athletes as possible. There's a lot of stress, as any other event. Some events are bigger than others. But I like, again, it's a diversity in my daily life. And I like that. That's sort of a break from my daily practice and clinic. So it's good.
Yeah, since they have that break, and it sounds like you guys all really work together to make sure that the athletes get the best care possible and are able to be successful.
We try, and I think the medical team we have at the moment for the Norwegian ski team, we've really taken it a notch up. We have spent a lot of time investing in trying to develop a system that's smooth for the athletes and for the coaches in case of injury or illness. We have really clear-cut rules for this and that, and do's and do not. We intervene in also the whole perspective of nutrition, also restitution and things like that. But we're really good athletic trainers on the team. But at the end of the day, it's a family type of atmosphere on the Norwegian team. And I mean, even somebody like Axel and Svindal, he will chip in and dig some snow if that's needed, and carry some poles. So the guys are good guys, the girls are good girls, and everybody is supportive of each other, but also know each of their roles. So it shouldn't be misunderstood that it's a family holiday. It definitely is a professional machine that is very, very well run and strictly run. But at the same time, we have a good balance of it not being too divided in hierarchy and you're better than me and back and forth. Even the athletes are all treated the same way and as being on the same level.
That's great. I mean, it sounds like you guys all you recognize that the goal is for everyone to kind of be successful and do well. So you all pitch in on a goal. So you talked a little bit about like the sports medicine team. So what does your sports medicine team look like, and like what are the roles for each person?
I think if you take the Norwegian team, it looks very different than any of the other dominating alpine ski teams in the world. We have a much, much lower budget than the US and Austria. And our medical team is very small compared to the US. I know in the US Ski Association or Snowboard Association, there's up to 200 people in a pool volunteering to travel with teams, but this covers both skiing, snowboard, Nordic skiing, and all the winter events. For the Alpine Ski Team in Norway, we are 2 physicians covering the whole team, men's, women's, World Cup, and Euro Cup. So we're covering all our alpine ski athletes. We are a staff of 10 physical therapists or manual therapists that are traveling with the team year-round. These manual therapists are typically people working in a clinic in their daily life, and then they organize, so they take time off from the clinic to travel with the team. So we're about 5 guys on the men's team and 5 guys on the women's team. So these are definitely, they have a lot of travel activity. So I'm the only orthopedic. My colleague is a general practitioner with a specialization in sports medicine and has worked for Olympic Training Center and for Olympic teams for the last 13 years, I believe. She was active with Nordic skiing for 8 or 9 years before she came into to the Alpine Ski Team. So we sort of divided up a little bit in the sense that she takes care of, general flu, cold symptoms, or anything that's medical or medicine related, where I take care of the injury scenarios, or if they twist their ankle or something related to injuries. We both participate in screening and prevention of the athletes. And then the traveling, as I said, we don't send a physician on majority of our trips. So we're available 24/7 by phone or by email. Okay. It's a lot of things over the phone. Our physical manual therapists are really experienced and with the team for many years and know when to call and what to call about. And then we can fix things, or we have contacts throughout Europe, US, or South America where we can call people and say, do you have a possibility to look at this athlete? So in contrast to the US team or the Swiss team or the Austrian team, I know the Austrian team has about 76 physicians, whereas the US team has about 200 physicians or medical personnel. We're a total group of 12 people. So it's very different.
Yes, and it's impressive that you guys, can still, you have all the medical needs are all the same throughout entire field, but you guys are able to kind of handle it all.
Yeah, I think I think the bottom line is it's a cultural difference. In the U.S., it's expected there's a physician on the field of play at any football game, pretty much any baseball game, NBA game, hockey game, at different levels, even from high school and up. Mm. This is not common in Europe, but we don't have American football, of course. We do have hockey. We don't have baseball. But the injury incidences in baseball is not that high, I don't believe. But I can understand in American football, it's a high impact sports again, but so is alpine skiing. But it's just a different cultural aspect that it sort of narrows down to. I think that the athletes are brought up, they're in a system where there are not doctors available. You don't have private practice doctors in Scandinavia, it's public hospitals. So we can't just, we don't have any commercial interest in being the physician for this and this team. So we don't gain a lot by doing it. We spend more of our free time doing it without any gain but personal.
And are there any challenges that come about that, like with not having people there on the sidelines or on the mountain or wherever?
No, all the big events, there will always be a physician there. The professional hockey team or the league of professional hockey, there's mandatory physicians in the arena. it's not necessarily their own physician. It's a physician that has to cover that game. Whereas in the US, you travel with the teams far and away. So I mean, the athletes are taken care of. They're not left in a bad spot, a bad situation. But I think for a lot of the American athletes and also the Austrians, it's expected that a doctor is there, which the Norwegian athletes are just not used to, and we just don't have the money to do it. So it's quite simple in that sense.
So I think you talked about a little bit about kind of differences between sports medicine in the U.S. And with Norway and other countries. What other differences have you noticed between, especially with sports medicine, between the two countries?
I think the biggest difference, I think, is the barrier between medical personnel and the athlete. There's definitely a bigger gap between the athletes and the medical personnel in the U.S. At least that's my sort of my sense of it. And when I talk to my colleagues as well, our athletes will, of course, challenge us in any kind of diagnosis or potential time off or a potential surgical procedure or whatever is being offered for that patient with an issue. Whereas I think the American athletes tend to be a little bit more higher demanding and have a more, not more of a say, but it's more, not a conflict, that might be too harsh a word to say, but it's a bigger challenge to communicate between the athlete and the physician. And I think my sort of perception on it is that our athletes do truly respect when we say, no, you don't need surgery for this. They're not pushing it as hard as I sort of get the feeling that they might in different countries, because the athletes, they feel they have more of a say. Where our athletes, I feel that especially at the Olympic training center, have a great respect for what we do, and vice versa. We greatly respect what they do, but the communication is much closer, I feel.
Interesting. So how about so you've kind of you've been involved in the STEMMing clinic in Vail, Colorado now for a year. What have you seen that's kind of different within the actual clinic aspect?
The clinic in itself, I mean, the medical aspect of the diagnosis and the background or indications for surgery are not that different. That, I think, is in general all over. There might be some parts of the world where people tend to be more aggressive on surgery than other parts. In Scandinavia, we are much more conservative than most of the world, I think, based on a lot of the research that's come out of both on especially ACL patients from the OSTRC and the Norwegian Institute of Medicine, Sports Medicine, where we have the opportunity to do studies where we can randomize between surgery and non-surgery and look at conservative treatment. Plus, we're a public health system in the sense that there's always a wait to get into our clinic and to the OR. People can't just go to the orthopedic clinic. They have to go through a general practitioner and then be referred to the orthopedic department. So there's a wait there. There's a bottleneck in that. Plus, there's a way to get into us then. And then by the time we have assessed them and potential candidates for surgery, there's also a wait. So you don't take your ACL and then get it done the next day in general in Scandinavia. And we know from several studies now that not all patients need ACLs, and maybe only about 50% will actually need it. And we're not stressed to say let's do rehab, because the difference is that, if they're unsatisfied with doing rehab, well, they can go to the other hospital, but they'll be offered the same thing. Whereas in the US, it's a private clinic, so it's all about the money. So they know if they say, well, you have to rehab for 3 months, and the patient say, I don't want to rehab for 3 months, I want surgery.
Yeah.
Then they're dissatisfied and they go to the next clinic, and then you lose that patient because that patient was going to have surgery no matter what because they put their mind into that.
Hmm.
So it's a different setting. The biggest advantage we have is we have no money between the patient and the indication or the procedure that we choose for the patient. So I will always sit with the patient, and I can choose what I feel is the best for the patient without thinking about the financial background, financial security of the patient, insurance, or what it cost my hospital, or what would it cost me to do this. I don't ever have to think about that directly. That is probably the biggest advantage.
Yeah, that's interesting too, because in my role as an athletic trainer, I find that that's one of the things I try and do is I try and save my patients money. So if they have an ankle sprain, rather than immediately sending them for an X-ray, we'll use auto ankle rules and say, look, there's a very limited chance that you have you need an X-ray. So I think that's very interesting that in your system you've really seen that that money aspect is not there, whereas in the U.S. system that money aspect is really a big part of and can really influence care.
Yeah. So we're in a fixed salary. Our clinic doesn't get anything extra if we do 100 cases extra a year, or if we do 100 cases less a year. There's money behind, there's a budget overall in the hospital, but it's nothing that we as physicians are involved in. We might get some kind of feedback from the administration saying, well, guys, you've been doing 30 of these procedures and they're really expensive procedures. Is this necessary? So they will question us on that behalf. And if we can argue rationally for it, for a medical point of view, we'll say, yes, this and this and this. All right, then it's accepted from the administration as well. So it's very, very different in that sense. But the healthcare, I think looking at the U.S. system, there's a lot of superstars in the U.S. system, and it's definitely being promoted in congresses and traveling the world and stuff. And these guys, they do phenomenal. They really do. And they're respected, very good surgeons, very good researchers. They work hard. They have long days and long hours. And that's probably one of the biggest differences between where I work and where everybody else is working, is that we're a public university hospital. So we have to shut down the OR at 3:30 every day. I can't put on an extra case. And there's just no argument for it, because the nurses, they go home.
Yeah.
Here, they go home when the surgeon is done.
Mm-hmm.
And I would probably like that a little bit more, that I would have a bigger say in how many cases can we do in a day. And I have this extra patient I would like to get in, and instead of trying to squeeze in every day or over the next span of the next couple of weeks. So there are pros and cons in every system.
So what do you think that the U.S. can learn from Norway, and what do you think, or the Scandinavian system, and what can Norway learn from the the USA system?
I think if we take the U.S. first, learning from the Scandinavian system, I think two things. One is less defensive medicine. There being a lot of extra additional things done before you get into the OR, or before they come into the clinic. A lot of papers to sign. It's crazy the amount of paperwork you have to go through here with liability and malpractice and stuff like that. And probably do less surgery, less aggressively, maybe give it a little bit more time before you admit this patient into surgery. And I'm talking mainly looking at the ACL perspective, meniscus perspectives, and even some of the shoulder cases. But I think what we as European or Scandinavian surgeons can learn from the US is probably be a little more involved, a little bit more dedicated. I know I'm generalizing a lot right now, but I do also have a lot of colleagues that look at the clock and say, "Oh, it's 3:30. I'm out of here." Where I feel that here it's a it's a business. You're taking care of your business. So you get involved personally, professionally, and you give a good service. I think that getting involvement at a little higher level than we have in Scandinavia, and a little bit more professionalism, and a little bit more of being problem solving and offering solutions instead of saying, well, we can take you in 6 weeks. When the patient, well, you know, my work and back and forth, well, sorry, that's 6 weeks. There's really no flexibility in our system. It's very black and white and very, very straightforward in that sense. Where in the US, there's a lot more flexibility. People seem to be a little bit more dedicated in that sense.
It's interesting. So I think you brought up some good points, and I think one area is, you know, for me being an athletic trainer from that standpoint, is that for those that don't know, an athletic trainer in the United States is someone that works, is in collaboration with physicians. They provide preventive service, emergency care, injury, illness diagnosis, therapeutic intervention, such as like rehab exercises, those types of things. And they kind of work all over the place. It used to be that they only worked in like colleges, professional sports, those types of things, but now they work with the military and the occupational health, such as like factories, health, and they work in health clinics and high schools. And so kind of the, you know, we're kind of the point of care, I like to kind of say that, you know, the athletic, the patient, if they're an athlete, they're active, whatever, and they have a orthopedic or sports medicine concern, they kind of see the athletic trainers first. And then the athletic trainer then kind of determines, okay, do you need to see a physician or a sports medicine or an orthopedic surgeon or whoever? And then when they are waiting for that care, whether it be surgery or whether it's, you know, rehab, they're going to a PT clinic twice a week. The athletic trainer kind of works with them on the side in collaboration with the entire sports medicine team. So, you know, that's kind of the benefits that I've kind of seen from an athletic trainer standpoint. Now, does anyone kind of fit in that role, do you think?
Well, we don't have that. Now, we talked about a lot. I mean, Professor Ingebrigtsen and I, we travel a lot, teaching on different courses around the world and giving talks and things, and visiting hospitals. And I think, you know, when I look at the clinic here, for instance, I mean, they can easily see 50 plus patients in a day. I don't have anybody. I have to pick up the patient in the waiting room by myself. I have to bring them into the room, talk to them, go through everything from A to Z, make the final decision. And then I also have to book everything in the journal. If I want to put them into OR, I have to do the booking myself. I have to write my report and do everything. I take blood pressure and whatever else is needed to put them into the OR. I write up the referrals to physio or to something else. I have to do all that. Where I see the teams here, they have, you know, they have fellows, they have junior attendings, they have ATCs, personal assistants. So they can easily go through 50 plus patients in a day and still have time to do other things. And where I will see maybe 16 to 18 patients in a day because I have to do everything and be done by 3 o'clock.
It's yeah, that's interesting, because I think that's one thing that orthopedic clinics are starting to hire more and more athletic trainers, and that's really to kind of optimize the time with their patients. So they kind of do the blood pressure, or they do the scheduling, and they'll even start a rehab plan before they kind of go in to see their physical therapist. They can kind of, you know, be the in-between spot. So it's kind of interesting that you know, I think the average orthopedic surgeon has like 6 minutes with each patient or something like that. So it sounds like you spend a lot more time with your patients, which can be.
I definitely do. I do a lot of secretary work, and a lot of a lot of the work for everybody else as well. That's how it's structured in the Scandinavian system.
Okay. And we're back with Dr. Marc Strauss. Thanks for moving offices.
No problem.
So we kind of left off when we were talking about kind of the differences between the healthcare systems, especially with the time that you spend with patients.
Yeah, it's very different than the things I've seen in the U.S. at least.
And so, do you think that is it helpful to kind of spend all that time with the patients from your perspective, or would it be more optimized if you kind of had some other providers that took off some of the load that your job requires?
Well, I think it would give me more time to do other things that are always falling behind on things and trying to catch up. So definitely, I think would give a less stressful day. But again, looking from a logistical point of view, if I were to see 50 patients in one day, I would very, very rapidly have a waiting list of 1 to 2 years before I could put the patients into surgery with the short OR days we have and the limited amount. So it's a natural bottleneck, so it gives a natural flow through the whole system because I can't do surgery from 7 a.m. till late that night and get a lot of I have till 3:30 and I can't extend those operating hours with the way the system is at the moment at least. So it sort of gives a natural balance in the waiting time, both to get into the clinic but also in the OR. So it's a balanced system.
So I guess my other question is, so when you're interacting with the patient, are there any other providers that you're working with on a daily basis, like especially interprofessional care? So working in a team with a patient to determine what the treatment plan will be?
No, I'm at the University Hospital. It's pretty straightforward. It's just you and the patient. And then if you feel that they need rehab, then you write them a referral to go somewhere in the city to have their rehab done. And then you make a follow-up appointment of some time, and sometimes you can get a report from the physio to see how did they do, did they work hard enough, or what kind of training program is it? Is this what you were looking for? At the Olympic Training Center, it's a little bit different. We have physios available all the time, so sometimes sometimes the physio comes into the clinic, say, I put up this guy or this girl for an appointment, and they join us for the consultation. And then we together say, okay, we're on the right track, continue with the rehab, or should we do something else? So a lot of times it's when the physios, they're like, okay, I've done a lot. I don't feel that we're getting a lot of progress. Why don't I just get an opinion? Or the athlete will bring their coach in, or even the training staff. So for the big athletes, we have a big meeting at the Olympic Training Center typically. So when somebody like Axel and Svindal or big soccer players or handball players get injured, then what we typically do is we make a team of 8 to 10 people at the Olympic Training Center. We sit down nutritionists, physical trainers, athletic trainers, sports psychologists, and everything, and then we make a schedule, and we do pretty much a day-to-day type of program for the first week or two, and then we make another meeting, and then we adjust that whole setup. So being a pro athlete and a potential Olympic athlete definitely gives them a much bigger team around them, a lot more follow-up.
Yeah.
Very much intense. We don't have the follow-up at 6 weeks, 12 weeks, or whatever it is, standardized, and that takes 9 to 12 months to get back from an ACL. It's a lot more individual, planned, and done.
So I mean, it seems like, when you're at that top level, you really have access to a lot of different resources. but it also sounds like maybe that's not necessarily available for the patients that aren't quite at that level.
No, it's not. I mean, if they want something similar, they can go. There's a lot of the physical therapy clinics in Oslo who are really high level. And we even sometimes, if we don't have the capacity at the Olympic Training Center, some of the athletes go to these centers. A lot of these physios that work there have either been at the Olympic Training Center or vice versa, that some of the physios have been working there previously and then come to the Olympic Training Center to work. So they're really respected physios, and I think the level of our physical therapy, especially on the sports medicine side, is a really, really high standard in general in Norway. And I mean, the general athlete or the high school athlete that really want to make it back have the opportunity, but you will have to put in economical resources to go that far and to do the rehab to a bigger extent than a normal average working patient that doesn't necessarily have to come back to athletics or top athletes.
Okay, so yeah, they kind of. So when you say they kind of need to put in more economics, does that mean they kind of pay for?
They pay for it. So when we make the referral to a physical therapist, there's some kind of compensation from the government, from public health system. But at some of these clinics, especially the highly renowned clinics, a lot of these physios don't necessarily have an agreement with the public health system, so they're self-paid. So you have to pay for that consultation, for that rehab hour out of your own pocket or through your insurance company. So Norway is a population of about 5 million people, and only about 500,000 or 10% of the population have private insurance. So it's a small population that actually have a private insurance, but typically these people are the active group that know that maybe I will need this one day. So it is different. It definitely is.
So yeah, it's interesting. I've kind of seen when my time in Sweden, I also kind of noticed that too, that the more active people were the ones that kind of had that private insurance because they kind of found like they needed that expedited care, which is kind of
interesting. They have less patience and they have higher demands.
Yeah. Which probably what a lot of American athletes are like too. It's maybe the athletic mindset is we have high demands.
Well, I just think, it's the culture because, I mean, in the U.S., if you are made to become something big, if you reach that American dream, it's something that is in the system. I mean, people that really want to prosper, they don't get pampered, but they get taken care of from day one. Whereas in Scandinavia, you don't have that same system in that upbringing. There's more of a saying that don't think you're something special type of attitude. So you keep your feet on the ground. I'm not saying American athletes are not like that. There's a lot of nice American athletes, absolutely. But there is just a tendency that you're being put up on that pedestal at a younger age, and you're being groomed to be that one at a much younger age, and it's much more harsh than in the Scandinavian system. So I think the personality also reflects a little bit on that it's difficult when you're 16 years old and you're being told you're going to be the best in the world to keep your feet grounded, solid and firm. It takes something special, I think, from that person in itself to keep their feet planted firmly on the ground.
Yeah, I think there's a lot of big difference between the Norwegian and American sports system, especially with youth sports. I actually watched it was a HBO special comparing Norwegian, and they talked about how no one under the age of 12 could be ranked.
Exactly.
And I was working one thing, and I met a 7th grade boy, and he told me he was one of the top 15 soccer players in the United States. And I was like, "You're 7." So it's very, very different systems. So from your perspective, what have you seen from the difference from, we've kind of talked about the healthcare system, but now about the actual sports system, what have you kind of noticed the differences and similarities are?
Well, I mean, the difference is not as big. I think the biggest comparison are the parents. Parents are getting more and more involved in their kids' athletics and careers at a very, very young age. We see that tendency also in Europe and in Scandinavia. And there's always the big debate on too early specialization, ranking. I think there are pros and cons. I've seen both sides of the system now, having two kids, a son who's 13, just turned 13, and a daughter who just turned 11. And for my son's sake, he was playing hockey on a team back in Oslo and was alpine ski racing as well. And trying to combine two winter sports is very difficult, especially hockey and alpine skiing. But his coaches on both sides had a great understanding that he wanted to do both. So when the schedule came out during the fall for all the hockey games and the tournaments, and also for the ski races and camps, then we sat down and said, maybe you can't do both of it. You can't do all of it on both sports. You will have to pick and choose a little bit, and also think to be a kid. And not think to be a professional athlete at the age of 11 and 12. And so he was really good about it. And he said, well, this is the race I really want to do. This is the hockey tournament I really want to do. And the coaches, the first year, I know they were a little bit skeptical, but they found out it was great. And when we saw his progression and his development compared to a lot of the other kids that had that one sport already there, his development was much, much greater than the others. So then we came to the US this year, and there were tryouts. So he'd never been on a tryout because his hockey club, there were enough kids to play two teams, but they split up the kids evenly, and they have to do that. They have to have equal amount of time on ice. And it has a positive and a negative aspect of it. The positive is that they have built over the years of a lot of good friendship, even though some of the guys are better and some of the guys are not as good. But the friendship they get and develop over those years has been great. But there's also frustration, especially for some of the good kids, in contrast to some of the less fortunate kids on the athletic side. It gives frustration both ways because the better kids will be not as nice or be frustrated in game situations, especially towards the not as good kids in a game situation, and the not as good kids will get frustrated for not being able to deliver and disappointing towards the team. Then you come over here, and if you are good at something, you can really prosper and you can be felt taken care of. And then you can also do a hobby type of athletics. But it was interesting to see my son, because he'd never been exposed to a system like this with tryouts and being challenged in that sense. I don't think I've ever seen him as nervous when he went to the hockey tryouts, because everybody had to go to tryouts to find out if they were going to be on the A or the B team. And he said to me, he said, well, if I make the A team in hockey, I'm going to stop ski racing. So he made the A team, and then he said, I don't want to ski race anymore, which I thought was great. And he's just grown. I mean, the joy and the challenge he's had in the system, being on a level as everybody else and being able to play on a team where everybody's equal leveled and everybody wants the same thing, has been great for somebody like my son. But I also see the downside in it. There are 100 kids at tryouts, 15 are taken out, and then 85% of them are being judged as not successful or failures, which you don't have at that early age in the Scandinavian system. And that's the same in the school system. We don't have grades until 7th or 8th grade in Norway. So they're never being judged directly on how well they perform. But at the end of the day, looking at the Scandinavian school system, they still do very well compared internationally. And Scandinavian school system is often compared to being one of the best school systems in the world. So the biggest difference, especially in the school, and I think also in sports, is that in the US, If you're good, you have the chance to develop and prosper.
Hmm.
And the ones not as fortunate, not as good, they get left behind.
Hmm.
Whereas in the Scandinavian system, we have to keep not as fortunate up to a minimum level. But if you're very talented or good, you don't get to prosper. So you get a little bored. So there are pros and cons in both systems. And it's just a matter of how you want to look at it. And I think it's very individual from person to person and from personality to personality, and also what you have or what natural gifts you were given by birth, and how you are as a person, how you cope with things.
It's interesting to kind of see the difference. And so is there a time frame or an age when they start allowing the separation of the levels? Or is
so this year he played Pee-wee hockey. So when he comes back home to Norway now, this is the first year they're allowed to divide into different teams.
Okay.
Our youngest, who loves ski racing and who loves playing soccer, we were talking about for her to attend the ski and snowboard academy here in Vail. But they wanted ranking, they wanted video analysis, they wanted statement from the coaches. And we said to them, sorry, we can't provide that. First of all, we don't videotape the kids. That's fun. Secondly, we don't have rankings, and we don't time the kids below 12. So we don't even have an official timing on these kids. So they ski for the joy of it.
Yeah.
But that was very difficult to have that discussion here that, well, you can't provide anything. Then she would have to come on a shadow day in the springtime to see if she was good enough to be accepted at the academy. And my thought is, she's 11 years old. If you look at, we have about 3,500 active alpine ski racers in Norway. And from that, maybe 1 or 2 kids will make it to become a pro skier.
Yeah.
So I think, if that's the focus, then you're losing a lot of people, a lot of talent. And what we've seen also throughout our national teams in soccer is that some of these kids making the U14, U15 and 16, even 17 team are not necessarily the ones making the A team at the end of the day. And when you hear a lot of these kids, when you talk to them when they're growing up, they said, well, I was always the best. And there were the guys making the A team, often the ones that are super hungry and they're just behind them, but never made that final cut in the youth ages. And then when you get into 17, 18, 16, 17, 18, you start losing a little bit of interest. And all of a sudden the hardworking one that was always in the background starts to take over and has that hunger and passion for it. With the others, it was a little bit too easy to get to. I'm not saying it's always like that, but it is in a lot of the situation, it is like that. So
yeah, you could see the differences between there and how that can develop. So you've touched it a little bit. So focusing just on skiing and snowboarding, the differences between the American or U.S. system and the Norwegian, what have you kind of seen there?
I mean, sorry, I didn't catch that question.
So the differences between the skiing and snowboarding clubs between the U.S. and Norway.
I think, I think everybody's moving towards that same path and road. I think there's too much money, there's too many parents involved in athleticism and in children today. I mean, I shouldn't throw rocks in a glass house, but I have 2 kids that are super active, and I'm also involved in both of these kids. But we have one motto at home that is, do it as long as you think it's fun. And when our kids, because they have a busy schedule, I look at when we were kids, we went to practice once a week. Now kids practice 3 or even 4 times a week, which I think sometimes is way too much. So when my daughter says, Dad, I'm just too exhausted tonight, can I please not go to practice? I think it's a fair argument. If as long as it's not becoming a habit and it's becoming like a pattern. But if you're tired and you're still a kid, so we have the philosophy back home that's saying, yeah, it's all right to skip a practice once in a while, but you also have to learn to be committed. So it's a balance, I think. But I think, the resources are strong among parents nowadays. So there's a lot of money in young sports today, maybe too much money, I think. I like the change in rules they made in the US now with the U12 skiing, that you can only have one pair of skis. You can't have warm-up skis. You can't have race skis. And there's no prepping of skis at the day of the race. And I think there was also talk about race suits, that there would be 1 or 2 races a year where the kids could wear race suits, I think. And I think that opens the door for many other people that might not have the resources. And alpine skiing is an extremely expensive sport nowadays. I talked to one of the girls from my son's class who is now going to Argentina for 3 weeks. I mean, she is 13 years old and going 3 weeks to Argentina to train this summer. I'm like, why don't you just hang out at the pool and play soccer, go bike riding? You're 13 years old, hang out with your friends.
Yeah.
It's turning crazy. It really is.
Yeah, definitely. There's a big difference. And that is, I mean, from my opinion, that is one of the hardest things about the sport is that it's so expensive. And, every single year, each race, especially in the U.S., each race is costing $50. And you have 4 pairs of skis that are worth $2,000 each. And
everybody thinks their kid is going to be the next big superstar.
Yes, exactly. So I think that was actually, with me personally, when I was in skiing and snowboarding, I was fortunate enough to grow up in Maine, where we had a public school system skiing competition. And so we just competed against each other's high schools, and it was funded by the local high schools. And so there wasn't as much pressure to have all the money and have all the best equipment and everything. And so, it was fun, and it was definitely competition, but definitely the money aspect was out of it. If I had told my dad that I needed to get 4 pairs of $2,000 skis, I think he would have told me to find a different sport. So
we had the discussion with my kids, because both my kids were the last ones on the ski team to get race suits. And I said, you're 12 years old. This race suit is not going to make a difference. And I definitely didn't want to be the one that people talked about being the team doc for the Alpine Ski Team, saying, oh, well, he's the team doctor, so of course they have a race suit. I didn't want to be that parent. So it became a principle for me as well. And I was never in that position when I was a kid to get all the equipment. And we actually had to sort of give in when the coaches came and said to us, Mark, you have to buy a race suit now. We would appreciate if you did this. So we gave in at the end, but we postponed it to as far as we could. And I saw the joy in my kids' faces also when they got that race suit, because it was a long waiting thing.
Yeah.
So it was a big thing. It was that goal line to get to, that when you're 12 years old, then you get that race suit,
Yeah.
So
that next level.
Yeah.
I mean, they may not be the most comfortable or warmest things in the world, but they make you feel cool, make you feel fast. So
they make you feel cool, and the kids, they love it. We saw the day we gave our son the race suit, he grew, 2 feet. And he just, skied with a smile on his lips like never before. But then again, it turns into day-to-day after that, so.
Absolutely. So
but it's not just soccer, skiing. If you look at soccer nowadays, which is a big European thing, I mean, these kids, they have 3-4 pairs of cleats to $200 a cleat. Which is like, why? We had, as we talked about, the big difference when we were kids to today is that nowadays there's the one kid that might have an old design of cleats, whereas when I played soccer, there was that one kid that had the last new model. Everybody else was wearing old cleats. That's the big change, I think, from sports from when I was a kid and to nowadays.
Yeah, definitely the big money aspect. So,
Absolutely.
yeah, everyone wants the highest and best gear.
Mm. But I think, it puts pressure on the kids, bottom line.
Yeah.
Especially in the world of alpine skiing, which is so expensive. It will easily cost you $25,000-$50,000 a year for a U14 skier.
Mm-hmm.
So if you imagine putting in for the last couple of years anywhere between 50,000 plus a year on your kid, since they were 10 years old, and then they get to 15, 16, and it's easily $100,000-$200,000. Well, not that much, about $50,000 a year before they start skiing phys, and that's when their injury happens.
Yeah.
So this 15-year-old next year is planning on skiing phys, and this has been the goal line the whole time, the first goal line before becoming a pro. They get their ACL, and they're 15 years old, and a lot of other things are going on in your life as 15-year-old. And maybe the interest for skiing is not as big as it used to be, and have maybe considered if you should stop. But these parents have invested a lot of money in you, and you're in debt to your parents. So I have a lot of these kids, they come into the consultation, they had torn their ACL, and they sit and they look into the floor, and the parents are doing all the talking. And then when you ask the kids, they look at their parents and they look back, they're like, yeah, I want to ski again. But I'm sure if you had them one-to-one and no parents in the room, they'll say, no, I don't want to ski again. And it puts pressure on the kids because they felt that their parents have invested a lot in me. They'll be disappointed if I quit now.
Yeah, absolutely. I mean, definitely the focus still needs to be on fun, but I think you brought up a good point that, with skiing and snowboarding, we know that there's such a high rate of injury. And so those injuries can be kind of big moments for the entire system, whether it's the athlete or the parents or whoever, and can put a lot of pressure on the healthcare provider and on the athlete themselves to get
and
back.
Also, it changes the whole game, because if you're 14, 15-year-old and you take your ACL, first of all, if you didn't take your ACL, your chances of making it to the pros are not very high. But if you then take your ACL on top of that as an adolescent, and then having to make the pros, I think that's almost an impossible task. There might be that one once in a while that will make it through that needle eye, but I mean, saying the chances of the 3,500 active skiers in Norway, that maybe 2 or 5 of them are going to make the pros, but if you take your ACL, I don't think you're in that 2 to 5. The chances of that are very, very, very slim, and that the parents still have that belief that they're the ones is tough and challenging.
Definitely. I mean, unfortunately, too, those are some crucial developmental years, learning the sport and advancing. And so, especially with ACL injuries, when you're talking, 9 months to a year until full recovery, and then depending on when it happens throughout the season, then it can really kind of impact a large period of time. So I guess that kind of brings us kind of to the next topic that we kind of want to talk about, is about injury prevention. And I think that's, where one of the things that we actually first connected about was talking about injury prevention for skiing and snowboarding athletes, and kind of the system itself and how it influences injury rates and those types of things. And like we said, with the injury rate is very high from the FIS injury surveillance system. They say about like 36.2 out of 100 World Cup athletes are injured every single year. And 30% of those injuries are severe, meaning that they're taking over a month to come back to snow, or a month or more to come back to snow. And these can kind of have short-term and long-term impacts on their health-related quality of life. Especially when there's a survey with retired skiers, and they all most of them said that they had low to poor knee health-related quality of life. So their knees were not in the best shape anymore. So, what is, for you, what does injury prevention look like for skiing and snowboarding? What does that look like for you?
I think, we put a lot of time and effort into it. Our athletic trainers on both the teams, they are very aware, and we all know that, the medical personnel is becoming a bigger and bigger role in top sports, and also the prevention and looking at the the soccer clubs throughout Europe, how much money is now put into medical health. We're looking at Chelsea and Barcelona to prevent, and the chances of having hamstring injuries and coming back after hamstring injuries, how much can that cost for you? It can cost you the Champions League. There's no doubt in mind on that. So there's definitely a lot of aware about it, and people are getting more and more educated on that front. We have been spending a lot of time with the ski team and the snowboard teams trying to implement this in their daily training. And the athletes in itself are also aware, because they see their friends getting injured all the time and hoping they're not the next.
Yeah.
So they're also saying, okay, I want to put time and effort into this so I can reduce my chance of getting an injury. So they're also very interested, and they see that the injuries are severe. They take a long time. For the alpine skiers, it's a lot of the ACLs, also for the snowboarders. And it's become a standard that if you take your ACL, of course you come back. I mean, if you look at the stats, that's not the guarantee. But it's just become a standard that if you don't come back, then something is wrong, you know. Well, it doesn't necessarily have to be wrong. It's just the outcome of the surgery or the injury. But we're putting a lot of time and effort into it. And in prevention, we don't only have the physical aspect of it. We're also looking at some of the other aspects. We're looking at stress and strain over time. We're making sure they're proper restituted, that they have enough time between practice sessions. We're looking at travel schedule. How can we optimize this to minimize the stress on the athletes so they get optimal restitution? Classic is that most of the athletes, they travel right after the ski race. They head out. And we know that we can actually reduce illnesses if we wait one more day. So if we wait till the day after. But the resources in the system is not good enough to implement that part of it. But we try our best to do something like that. We look at all the statistics around the world, what are coming out, and where can we improve. But it's a cost benefit also. I mean, how much money can we throw into this? Because an extra day at the hotel will be expensive. So, and there's a budget that has to work out at the end of the year also. Nutrition is a huge aspect. The athletes are getting more and more aware. I think the older athletes are easier to work with because they have been in the system long enough, and the older they get, the more aware they are. Where the younger athletes think they're immortal, and so they don't really consider it that much. But it's a culture we try to implement, and especially when the new guys and girls get in on the team, we use a lot of time and effort to raise them in a proper way. So we already down at the Euro Cup team, when they're younger, we already start implementing these rules and senses, but we just don't have the same resources that we can put that much attention into it. And they are not as dedicated. They're not mentally developed as a pro World Cup skier is a lot of the time. So it's more challenging. We have to be more repeating ourselves more and more and more and more before they sort of pick up on it. And because sometimes they have to change the whole daily rhythm, their perspective on foods, when to go to bed. We're making them aware of screen time in the evening. It postpones your sleep for an hour and a half to 2 hours. So we try to, and the athletes, the responsible athletes, are aware of it, and that they're not on screen time in the evening. Try to rest and get a lot of fluids to drink and eat. Make sure they have enough calories in there and diverse nutrition, so they get all the supplements that they need.
Yeah, definitely. I think you brought up a bunch of really good points. That injury prevention, it's not just, well, I got to do the strength exercise, or it's not just I have to eat a good meal after my race day. It's really a comprehensive approach, and you have to really look at so many different elements and so many different things that can influence the human body and its performance.
Yeah.
So I guess so basically you have the Norwegian system. You're trying to educate the athletes on what they should do. From a research aspect, what's kind of been the focus there? What have you kind of looked at research-wise? what are you guys looking at?
Well, if we look at the alpine skiing, and we know ACL is the big killer, and that it is one of those things we can prevent. So as Myklebust and Ingebretsen showed, that we can actually reduce ACL injuries by 50%, at least in handball sports and soccer. So we definitely implement a lot of these exercises.
Yeah.
And then we also we individualize it a little bit, looking at the age of the athlete, because a 20-year-old athlete who's getting stronger and stronger, we can probably push a little bit harder, we can probably challenge a little bit harder, whereas an almost retired athlete of 30, 35 might need restitution. So those are some of the aspects we're also looking at. We're individualizing, but we're definitely going for a standard of doing prehab protocol, not prehab protocol, but prevention protocols that we know are effective. The FIFA 11 Plus is a good tool for a lot of sports with simple exercises, but you also have to be careful you don't kill the daily training with too much exercises. I know I have a colleague back home who's a phenomenal physio and a good rehab specialist after injury. And as he says, when he works with kids, he's like, I know I can only give them a maximum of 3 exercises, and it has to take a maximum of 10 minutes. If I give them more exercise or it takes longer, they lose interest.
Yeah.
So especially in the young population, I think we have a big challenge and a big responsibility to involve the coaches in a young age. Because looking at soccer and big ACL kills, especially for the women, this is where we really can make a big difference. But we have to involve, the junior level sports already there and implement in the systems there and make them aware.
Yeah.
And I think for the kids, I think we have to reduce the amount of practices, the amount of scheduling of games and races. It's too much for them. So we typically have a rule at our house where we tend to take our kids out of practice 1 week every 7th to 8th week to give a restitution week. And then we also follow our kids in their growth. So if they're in a growth spurt, then we know they're more disposition for jumper's knee and issues with growth plates and stuff like that. So that's where we say, okay, you might want to have to just step down for a while to reduce that risk of injury. There's not hardcore evidence on that, but it makes sense in a common perspective.
Yeah.
I think we have to teach, the clubs and the coaches and the junior level clubs, but also the parents have to get involved in that. On the professional level, I think clubs are doing a lot. I think teams are doing a lot, and it's definitely not accepted if you don't have a proper prevention protocol. I think most teams nowadays.
Yeah, it's definitely, definitely people are going more towards that way. They're realizing it. And I think you brought up a good point that you need to look at the younger people and really start small and kind of build from there.
Yeah.
And then constantly be learning and teaching and kind of incorporate it throughout the entire culture. So it sounds like your system, is there anything that you kind of measure or checking to kind of see if any of these interventions are working? And then you mentioned that if they're going through a growth spurt, or are there measures or tools that you're using?
We've done it at the club level in Norway, especially in handball. And what we did see is when Myklebust, who did her PhD on this back in the days, what she did see is that with implementing this in the clubs, but being involved, they reduced the ACL injury rate by 50%. And then a couple of years, 2 or 3 years after, they saw an increase in ACL injuries again. And that's because they were not the ones pushing the prevention programs. All of a sudden, it was up to the clubs. And then it sort of faded out. Yeah. So it didn't really pick up and stuck with the club, unfortunately. And that's one of the things that has to be worked on. What we do with our top athletes, we test them several times a year. We do strength testing, we do agility testing, and then we have a baseline to see where were they at compared to the previous year, or throughout the season, where are they at? Is there something we need to work on that we should be aware of? So we definitely do a lot of tests throughout the year also. So try to follow them. Whether it's the right way to do it, we don't know. I mean, we just know we can reduce ACL injuries with proper prevention. And then again, injuries will always happen. Shoulder injuries, ACL injuries, no matter how much we do, they will always happen. Especially in skiing, it's a high velocity sports activity that sometimes the forces are just too great for humans to even withstand.
Yeah.
Soccer is that one split second, or same with handball, football, non-contact injury. Yeah, we can reduce some of it, but I don't think we'll ever be able to remove it from the sports.
Yeah.
Genetic disposition is probably the next interesting thing that people are going to start touching on. Anatomical variations in a lot of perspectives.
Like the intercondylar notch and those types of things. Yeah.
Slope, condylar notch, alignment, or is it just secondary to something else that we haven't discovered yet?
Right. And two, we have to be kind of realistic about our prevention methods, as well as, we look at the Caroline Finch when she came up with the TRIP method about 10 years ago. You really have to understand the culture of the sport, and then that can kind of help with the injury prevention measures. We could, for alpine skiing, we could probably reduce the DINs down to 1 or 2, and their skis would pop off at any moment, and it would really reduce the rotational forces. But also we know that almost no athlete is going to go down with their DINs set super low, and their skis are just going to
that would actually make the sport even more dangerous.
Yeah, right. So other injuries would come about. So exactly. So you just really have to kind of be realistic with your intentions, and then understand the sport and the culture, and then but trying to educate and incorporate small things.
And I think we're pushing limits, especially if you're looking at the alpine ski world. I mean, the equipment they have nowadays, those skis, once you go in, you put your skis on rails. They don't budge. It's your knee or your thigh or whatever that budges. It's not the skis anymore. Skiing with Flex 170 boots and 2 meter plus skis that normal people can't turn. And a lot of G-forces in the turns that come instantly. Really at a spontaneous moment, So I think the forces are just overcoming manpower at the end of the day, a lot of the times. And then I think, it's something we're always discussing is do we have a wear and tear or stress and strain on ACLs? So maybe they at lower loads will happen to rupture. You see it sometimes in skiers and soccer players. They're like, how is that possible that that person tore their ACL with this minor pivoting or minor twist that they've done 100 times before? Is there something about that they get overuse injuries, like an Achilles irritation? Can that happen to the ACL? I mean, I don't see why not. And then maybe the forces that they need to tear it are minimal compared to when it's strong. Helpful.
Definitely. I think it's kind of an interesting thing, and I've noticed when I was working with skiing and snowboarding athletes that they fall all the time, right? And so that's just part of the sport. They fall, they run into a B-net, whatever, and sometimes they have just small injuries, but they, at least in our culture or the culture that I work with, is that you just kind of, if there are small injuries, you just kind of push through it. If you could stand, you could ski, you push through it. But was there some sort of small partial tear during that time period, or did they get evaluated properly? Did they go have enough rest? There's a lot of different components that's unknown as far as knowing if there was any effect. So.
We're trying to simplify a complex process,
Almost impossible to do.
Absolutely.
So as far as research goes, like what do you think should be the next steps for injury prevention research for skiing and snowboarding?
Well, I think we have a lot of good steps. I think the surveillance program is really important and has contributed a lot. I think that the feeling that you're left behind with sometimes is that are people being honest and upright about the reportings. And this we have discussed before. I think especially in different cultures that they might withhold some information pre or post injury, so we don't get the full picture. But I definitely think, you know, there's been put a lot of resources and money and time into prevention programs, surveillances. It's given us a step closer in the right direction, I think. And where the next step should be is always a good question. We thought that we did something right by changing the turning radius on the skis, which did not really prevent the ACL injuries. And I think also, and if you look at soccer, the big discussion has been, is the schedule too hard? Should they have more time for restitution? That might be next step to go. But at the end of the day, I mean, it's all about the money.
Yeah.
I mean, the clubs are there for the money. The players are there to perform and to make the money for the club. So that's expected. It's going to be difficult to say that that you pay so much money for Messi, and then he's only allowed to play 2/3 of the game in order to reduce his chances of an injury.
Yeah.
I think that's going to be a difficult discussion. I'm not really sure. I haven't really come up with a solution for where we should go with the next injury prevention. I think we're on the right track. We need to dig even deeper. I think our biggest, where we can harvest the most is probably to catch the adolescent group and give them a good upbringing on prevention.
Yeah.
So once if they go through uninjured and they go into the pros, that they're already there.
Yeah.
They don't need to learn to do injury prevention. They're already really good educated and have a good broad base that they can continue building on.
Yeah, I think definitely brought up good points. And you know, the injury surveillance system, it's one of the hardest things, but it's definitely valuable to implement. I think, like you said, there's also some recall bias where depending on the system, it's harder to recall an injury that happened throughout the season compared to something, you know, if you're constantly collecting data throughout the year. And then also, what else was I gonna say? Went over a lot. And yeah, having a good approach going from younger to older is definitely something that's very crucial and important component.
No. I think getting parents and coaches more involved and have the parents back off a little bit might be.
Yeah, that's always helpful. Hard to do, but definitely important. And two, I think the other thing is is actually the data collection part is so hard. I think trying to prove like injury rates is really a hard goal to meet. So I think, you know, short-term goals and, you know, other data points that you can look at are really important. I know that one person I think Sporty mentioned do not finish rates, you know, compared to injury rates as being another data point to kind of look at, rather because injury rates they're hard to kind of look at and they require a lot of data collection. But if you look at other data points, I think that's really helpful to kind of compare interventions. And also, I think too, with looking at intrinsic risk factors and looking at different performance measures, I think a lot of times the studies that have looked at strength and different performance tests really only looked at things throughout the season or at the one time point throughout the athletic preparation, but really kind of seeing things throughout the entire athletic season and seeing how their bodies change and looking at fatigue and looking at muscular imbalances throughout the year and how their bodies change and develop. I think that, those are some kind of interesting points to kind of look at that can kind of, give a better insight of interventions that might need to be influenced. So,
Absolutely.
So kind of last thing is for injury prevention for alpine ski and snowboard athletes. What are some steps that current athletes, coaches, clubs could do for injury prevention?
Well, I think if you don't have an injury prevention program, I think it's time to sit down and do some research and find out what kind of that we're dealing with and how can you reduce injury rate by implementing simple prevention systems. I think the FIFA 11 Plus is a good, simple system that you can work with. There's also the Get Set app from the IOC, which is a free download app with a lot of illustrative videos. You can look at sports. You can go in and you can lock in on the sport you're doing, and it will give you different exercises. Or you can go and look at a body part, and it will give you video illustrative exercises. So I think you definitely need to have a prevention program in the club or with the athletes you're dealing with. At least offer that, and then keep it simple. Like I said, maybe those 3 exercises, max 10 minutes, but implement it in the daily training. And then for the kids, it has to be fun. If it's really sterile, non-inspiring exercises, it's a no-go. It's a dead end. So you really have to be creative and make this a fun part for the kids. And I think there's a lot, especially in the FIFA 11 Plus, that can be done not as a competition, but in a fun way that they can see how they're getting stronger and it's getting more and more fun to do the exercise. So you can take them as a challenge instead. So I think you definitely in the youth programs, kids sports, you definitely have to implement prevention programs as step one.
Yeah.
And you have to get involved and find out what it is. And I think we have to take care of our kids, make sure they get proper sleep, and especially with these modern days with iPhone, iPad. At our house, I mean, after dinner, there's no iPhone or iPad. It's family time, and make sure that our kids get a proper amount of sleep and good, variable, healthy foods. Make sure they get their veggies and they eat. I mean, we try to teach our kids to be responsible. If they want to do sports, there's a responsibility that comes with it. I'm not saying that my kids are going to go pro, and I'm not sure I want them to go pro if they have the chance. But it's part of teaching, and it's learning, teaching them responsibility and taking care of themselves. I think the tools of eating healthy, getting your night's sleep in a young age is definitely going to teach you some good values later in life and how to do things.
Okay, I think you did a good job kind of summarizing some kind of things that we kind of talked about. So thank you very much, Mark, for taking your time to talk with me. I really enjoyed our conversation. I feel like we could probably talk about this stuff for hours and hours. So
probably could, yeah.
But we'll maybe have to have some more conversations later on.
Absolutely. Well, thank you very much. Appreciate it. Greatly.
Thank you. Wow, so that was a really great interview with Dr. Marc Strauss. He really provides some interesting perspective on a variety of different fields, healthcare, sports medicine, sports themselves, and kind of the culture of Norway. And I was really glad that we kind of covered all these different topics because I think it really kind of helped give a full picture of how things kind of influence each other. I think it really helps that he's lived in both the United States as a child and as a healthcare provider in Norway, and then he's been involved in a healthcare organization in the United States, and he's also been a parent, so he's kind of seen all these different roles. So first of all, talking about like his daily responsibilities as a physician, that seemed just completely different from especially the orthopedic sports medicine physicians in the United States. He spends a lot more time with each patient and isn't reliant on nurses doing blood pressure and people doing scheduling and all these different roles that people play in each office that's in the United States. He's kind of in charge of everything, which I think is interesting. And he didn't seem to be in any rush about it either. And so I'd be kind of interested to kind of see how that benefits, how that doesn't benefit. I could easily see him spending more time with the patient. He himself kind of understand more of the entire disablement model, because he understands more of the patient, he understands their blood pressure, he's with them a lot more time, he can talk to them, and he can also kind of understand their schedule and what their work is actually like, and schedule when they schedule their surgery. So I thought that was just a very interesting perspective. I also kind of liked that kind of seeing the Norwegian Alpine Olympic Center, how they kind of do things is very different, especially compared to the U.S. with 200 plus healthcare providers compared to 10. And I was also surprised at how they were reliant on other countries and other healthcare providers that aren't from Norway to help each other out. So I think that's really great that as a team, as a healthcare team, going with them on these Alpine World Cup tours, that they can come together and they're willing to help each other out. And also that everyone pitches in general, just because you're a physician. I was surprised to hear that he carries gates down the hill and puts up bee netting and stuff like that, because that's not always an easy task. But it's kind of good that he's involved in the workouts and stuff, so he can really kind of see exactly everything that needs to happen. But he's also part of the team in general. I found it interesting as well that, for these elite athletes, he found it helpful to have all these different healthcare providers kind of in one room, the physiotherapists, the physician, the dietitians, they all kind of work together. But he didn't really see the same connection for the regular population, everyday population. So I found it kind of interesting that he didn't really see that connection. But he seemed to not feel like it was as big of a deal, because he could just refer to those people as he seemed to need. But like I said, I felt like culture really plays a lot into this. He kind of mentioned that, the U.S., we want things to happen fast. We expect a lot of our youth, and we are constantly comparing against one another. Whereas with them, they can't even compare against each other until after the age of 12, especially in sports or in grades or anything, which made it interesting for when he came to the United States with his children. But, I just found that interesting, and I think it plays a lot into that culture of the United States compared to the culture of the Norway. United States seem to be kind of rushed. We want care right away if we can afford it. Whereas in Norway, they seem to be okay. Like at least the physicians seem to be okay with things taking a longer time, and doing things right away, but also not ranking people, not comparing against one another. You kind of get the care when you need care. But I just kind of wonder if people are avoiding care because in Norway, because they know it's going to take so long or a longer period of time to get that surgical consult. Which is where I kind of wonder if it's be helpful to have a person like a role, like an athletic trainer, to kind of help with that and be on the sidelines for those minor injuries before that threshold of, okay, I need to go and see a physician. Also, really enjoyed hearing about the prevention strategies and things that they're doing. So I think that as a injury prevention internationally, we can really learn from each other what each other are doing, and I think we can kind of aggregate our data and do more teamwork to help to reduce injury rates, injury occurrences. So yeah, overall really good experience. Really enjoyed it. Kind of hope that this was a good connection, and I can continue to learn more about international athletic sports medicine. Thanks.